Hi everyone, I am Diana. I am to talk about Mosaic effects of wrong harmony on fibrous dysplasia of bone. Definition: fibrous dysplasia is rare, non-isolated bone disorder of scleral development that involves the growth of scleral-like tissues instead of normal bone. This irregular use weakens the after bone and gives it to the form of fracture.
This is Dr. Gabe from First Look MRI. This is a 16-year-old female. She had a pre-op x-ray to get knee surgery, and they just happened to catch a bone tumor up here in the femurs. This is the femur. This is the distal metaphysis here, and we see this lesion that fills the medullary cavity. This is a stir sequence. This hyperintensive stir. We see these sharply defined margins. And this hyperintense, kind of mixed hyperintensive stir signal intensity, but really sharply defined lobulated margins. On this T1-weighted sequence, we see that there is some fatty marrow centrally within it. We see that the cortex is thinned along the back, lateral, and anterior parts. The medial side is kind of funny lobulated, so there's endothelial scalloping and thinning. There's also marrow within this. We go superiorly, get into the normal marrow, normal cortex. Distally, we see this funny area of darkness here. This is bony sclerosis along the inferior margin. So it has marrow elements, endothelial scalloping. Looks like it's minimally expansile. It has this dark area down here in the bottom. This is a T2-weighted sequence, so it looks very, very similar to the T1-weighted sequence. There's no fluid pockets within it. This is a coronal T1-weighted sequence. We see that funny marrow coming down, going right into it. You see the endothelial scalloping. You see that low signal sclerotic component down here distally. If we put up the sagittal image here, we see the same thing. This is kind of peculiar. You can see that nice, clean, sharply defined margins. There's no edema within the cortex, no perilesional edema. And you can see the endothelial scalloping, minimal expansion. Here's that again, fibrous area down here and bone sclerosis. So one last view here. This is just another PV fat set sequence here. You can see the sharply defined margins, endothelial scalloping, and lack of perilesional edema. So this is a classic look of a fibrous dysplasia. And sometimes the bone can be larger. A lot of times it's angled. There's no angling of this, but just the sharply defined margins, the narrow zonal transition, the mixed areas of bone sclerosis, and intermediate signal, and the normal marrow just looks like fibrous dysplasia. Can't tell for sure, but other lesions that are non-aggressive, like an enchondroma, would be also common. Just wouldn't have this marrow going into it like this, and it would be more ovoid, and it wouldn't have the bone sclerosis on the bottom. You would see these speckled calcifications, chondroid matrix within it. And so with an X-ray and this MRI, I think they can confidently say that it's a non-aggressive lesion, probably fibrous dysplasia, and they will probably shell it out and pack it with marrow and just prevent her from getting a pathologic fracture someday. And that's it. Thank you very much.
Applications in medicine. The main tool for the diagnosis of fibrous dysplasia is the X-ray. Although the bone appears solid on X-ray, a fibrous dysplasia lesion has a distinctive appearance that is often described as bone loss. Therefore, this disease can be diagnosed in a person who does not have symptoms and who has X-ray for other reasons.
Hello everyone. In this short video, we will discuss about the radiographic appearance of fibrous dysplasia. This topic is very important for your exam preparation, so stay tuned. First, we will discuss about the location. Fibrous dysplasia involves the maxilla almost twice often as the mandible. It is an important differentiating point. In some cases, ossifying fibroma can be confused with fibrous dysplasia. But remember, ossifying fibroma is more common in mandible and fibrous dysplasia is more common in maxilla. FD most commonly involves the posterior region and it is commonly unilateral and very rarely bilateral. Now let's discuss about the periphery. Periphery of the lesion is most commonly ill-defined and blends imperceptibly with normal bone. If you see, other radiopaque lesions have a demarcated border. So this point is worth remembering. Periphery of the young lesions sometimes appears to be sharp and even corticated. Now internal structures. Density and trabecular pattern of the lesion vary considerably. Variation is more pronounced in mandible and more homogeneous in maxilla. Here you can see. The internal aspect of bone is of three types: more radiolucent than normal, less radiolucent than normal, and mixture of these two lesions. The early lesions appear as a cyst-like radiolucency in the jaws. Sometimes it appears to have granular internal septa, giving internal aspect a multilocular appearance. If you see the trabecular pattern, they are shortened, thinner, irregular shaped, and more numerous than normal trabeculae. The altered trabeculae may give rise to various appearances like orange peel, ground glass, thumbprint, and cottonwool. Simple bone cysts like bone cavities are seen and occurs more commonly in mandibular lesions. Now let's discuss the effects on surrounding structures. Small lesion has no effect on surrounding structure. Fibrous dysplasia typically causes enlargement of the bone from within, which can cause a ribbon-like thinning of the cortex. Expansion of the bone is even along its length rather than the more concentric expansion seen with the benign tumors. Here you can see the vertical depth of the mandible is often increased. In the maxilla, the lesion encroaches the sinus, usually from the lateral wall, and last section of the sinus to be involved is the most posterior superior portion. Normal anatomic shape of the antrum is most often maintained, which is a differentiating point with other tumor-like lesions. Superior displacement of the inferior alveolar nerve canal is another typical finding of FD. In case of other lesions, the canal usually displaced inferiorly. Now, lamina dura of the teeth in the affected areas of the bone becomes indistinct, and pedial space may appear to be very narrow. FD can displace teeth and interfere with the normal eruption. And remember that root resorption is very rare in that case. I want to pass your...
Pros and cons. Pros: fibrous dysplasia is a genetic disorder. There is a use of genetic mutation that is not transmission from parent to children. And cons: this disorder has no cure, difficulty walking or living.
Liam is a 5-year-old, and he has a rare bone disorder called fibrous dysplasia. It forms fibrotic tumors throughout his bones. He also has a second condition called rickets, so it makes his healthy bones very prone to fracture.
When I first met Liam, he was about 18 months old. He was not walking, not feeling well, and now he is a different kid.
IBJI is in the forefront of treating bone disease and fractures. If we hadn't gone to IBJI, he would have either not healed correctly or been in a lot of discomfort for quite a long time.
The fun part about doing pediatric orthopedics is I get to see them grow. And for someone like Liam, where the diagnosis was unknown initially, to watch him go through the process, he's doing great.
This is the plate in Ecuador. The worldwide incidence is unknown, but the frequency of bone cases per million inhabitants is estimated. Video.
I can remember an old joke somewhere along the line that said, the moral majority is neither. Well, here we have a case of fibrous dysplasia. I cannot say that fibrous dysplasia is neither, but I can say it is not truly dysplastic from the malignant sense of the word. Fibrous dysplasia is a very, very rare disease. You'll probably never see it in real life. It's a result of a mutation of some gene, but the mutation usually occurs during fetal development and is not hereditary per se. What you can recognize in this biopsy, also fibrous dysplasia is usually involving one bone most of the time. It could be multiple. What you can recognize here is the fact that these darker purpler areas are trabecular bone. You can see the spicules. You can see that they are peripherally rimmed by osteoblasts. You can see that they are inhabited by osteocytes. But in contrast to most bone, this marrow is completely overgrown by a proliferating fibrous tissue. This is a very classical appearance for fibrous dysplasia of bone. Thinned spicules, mostly because of a tremendous overgrowth of fibrous tissue between the spicule. Do I have to show you anything more, or are you happy? Here's the fibrous tissue. Notice there's a lot of blood vessels within the fibrous tissue because this proliferating fibrous tissue needs a lot of blood, doesn't it? Here's a nice spicule of bone. For that reason, this is trabecular bone because spicules are also called trabeculae. And like any spicule of bone or trabecular structure, you can see osteoblasts towards the outside of the spicule, and any nucleus you see within the bone is probably an osteocyte. Thank you very much.
And conclusion. Fibrous dysplasia is a rare bone disorder that involves the growth of scar-like tissues instead of normal bone. This irregular disease can weaken the affected bone and cause it to deform or fracture.
My name is Sam. I am 12 years old. I have a rare bone disease, fibrous dysplasia. Basically, what it means is that pieces of my bone and my skeleton are very porous. My left leg is so porous that my bones break really easily. All I do is stand on it, and before you know it, it's broken. It is caused by benign tumor cells eating up the bone and replacing it with a kind of chewing gum-like cells. The first time I broke my leg, I was 4. By now it has happened 15 times. The last time I was in plaster for 18 weeks, from my toes all the way up to my belly button. Because of all these fractures, my leg doesn't grow straight anymore, but in an odd curve. I have difficulty walking, which is why I have a mobility scooter. And I will be getting an electric bike soon, for when I go to secondary school. My doctor is called Dr. Dijkstra, and he works at the University Hospital in Leiden. He's been treating me my whole life. He tries out all sorts of things, special titanium plates, for example. Or he grinds into my bones and then fills my leg with healthy bone particles from the bone bank. And each time we have to wait and see what the effect is. He has operated on me so many times already. Because the disease I have has never been researched anywhere in the world, Dr. Dijkstra has to find out everything for himself. Of course, he doesn't do everything alone. Dr. Hamdi, who knows everything there is to know about bone metabolism diseases, helps him. That is why Dr. Dijkstra needs money for research, so he can better understand where the disease comes from, and I might get better one day. Sometimes I feel quite sad when other children call out, "Hey Gimp," for example. I sometimes get angry inside, and I just feel like trashing everything. But it doesn't help. I just feel it is so unfair that I have this disease. It's also unfair on my parents and on my younger brother Kik, too. Always in and out of hospital. Dr. Dijkstra calls it a debilitating disease. I don't like to hear that. I try not to think too much about what that means exactly. What I do think about is how I can raise money for research into fibrous dysplasia. Dr. Dijkstra's research, Better Bones, costs €250,000. That is an awful lot of money, but I'm certain we can raise it. Will you help me?
Please contribute to the research into Sam's disease, fibrous dysplasia. For more information, see bontiusstichting.nl.
Thank you.